So in the meantime, Dr. Lapp,
Yes,
we can get started. How exciting is that?
great.
Great. So I'll just say welcome to everyone. For those of you who don't know me yet, I'm Lorrie. I'm a holistic coach, and I developed the Relief and Transformation Managing Long COVID and MECFS FM course. I also offer free workshops every other week for long haulers and CFSers and other chronic illnessers. And I'm really passionate about empowering people with long COVID and other chronic illnesses to find emotional and physical relief with these tried and true methods that I've developed and learned over the past 20 plus years, with a lot of other people's input as well. So I have my own personal story with MECFS FM and now long COVID that I will share with you at some point. But right now, I'm so excited to introduce Dr. Charles Lapp. So Dr. Lapp is really a legend within the chronic fatigue syndrome, myalgic encephalomyelitis area, and other related illnesses. He's one of the pioneers of treatment and really of taking these types of post-viral syndromes seriously. He founded the Hunter Hopkins Center in 1995, which specializes in MECFS-FM. He was on the federal advisory panel for MECFS, served as a board member for the American Association for CFS and the American Fibromyalgia Syndrome Association, and tons of other things. So you can tell he's kind of a big deal. So welcome, Dr. Lapp. Thank you so much for being here.
Thanks, Lorrie. Glad to help out.
Awesome. So I'd love for you to share with us at some point why you became interested in treating these syndromes. But first, I'd love to hear your thoughts about long COVID versus MECFS. So to me, they seem like it's all a part of the same big picture, but I'd love to hear your thoughts on that, if they're different, if they're the same.
I imagine they're about the same. It's well known that viral illnesses can trigger chronic fatigue syndrome or at least post-viral fatigue syndrome, which is very similar. Now, not everybody that has long COVID, which means that they have symptoms lasting longer than 3 months after the onset of illness. There's a group that has maybe 1 or 2 symptoms that persist for a long period of time, and that may be for many months. The ones that have the MECFS have the classical symptoms of chronic fatigue syndrome, namely exertion intolerance, post-exertion malaise. They have a sleep disorder, typically non-restorative sleep, and either cognitive problems or upright intolerance, dizziness, and maybe some orthostatic intolerance with POTS or with neurally mediated hypotension. So there's really 2 types of long haulers, the milder ones with 1 or 2 symptoms here and there, and then those that have converted into the chronic fatigue syndrome with those classic symptoms.
Great. That's very helpful. So, that was kind of what I was thinking too, but it's so interesting to me that that not more people, or not more doctors, not more of the that people aren't bringing in the knowledge of chronic fatigue syndrome and myalgic encephalomyelitis and things like that within.
That's my concern too, Lorrie. I think a lot of people out there don't realize that they fit the criteria for chronic fatigue syndrome, or MECFS as we call it. And when they go to centers that proclaim to be long COVID centers, I think there's a big chance that they will miss that diagnosis of chronic fatigue syndrome and POTS, which is another postural orthostatic tachycardia syndrome. And in POTS, when people stand up within 5 or 10 minutes, their heart rate goes up by 30 beats or more, and they start to have a lot of symptoms. And those symptoms are autonomic symptoms, of course. It's an autonomic disorder that goes along with chronic fatigue syndrome. It's one of the comorbidities that we see in many cases of chronic fatigue syndrome.
So is MCAS, mast cell activation syndrome, also considered to be a typical comorbidity with?
It's not typical. It's one of the subsets that we do see. I don't think we have established it as being a typical comorbidity, but we certainly do see it in chronic fatigue syndrome.
Okay.
Yeah.
Great. Yeah.
There are certain things that occur with such a high frequency, like irritable bowel, overactive bladder, low B12, low vitamin D, dry eyes, dry mouth, EDS, which is Ehlers-Danlos syndrome, or joint hyperextension. Those things occur so frequently that they're considered typical comorbidities of chronic fatigue syndrome. There are actually about 35 or 36 of them now that have been identified. I still don't put mast cell activation in there, but we certainly see a number of patients that do have mast cell activation.
Interesting. How can we access that list that you have?
I can provide it.
That would be great. I'd love to send it out to people afterwards.
Sure.
Yeah, I'm going to write a note to
I'll write a note too.
Oh, great. So within that, are you noticing that people with long COVID tend to have some different symptoms than people with chronic fatigue syndrome? And I know that's a really difficult question because every chronic fatigue syndrome person, their experience is different.
Well, we see slight differences. The patients with the COVID tend to have, I think, a little bit more headache than we typically see with chronic fatigue syndrome. And they have that anosmia, that inability to smell, and dysgeusia, inability to taste,
right?
Which can last for a long period of time. Many of our patients have some chest tightness or chest pain, which is not typical of chronic fatigue syndrome. It's seen in that, but it's not as typical as it is with the long haulers. I'm trying to think, the shortness of breath, of course, and cough. They tend to persist a long time as well. So again, we see these things sometimes in chronic fatigue syndrome, but much more in the long haulers.
Okay, great. Yeah, that's good to know. Because again, it's just, it gets so confusing. I know that Dr. Fauci just came out with the term post-acute COVID syndrome. And I really just kind of wish that people would say, hey, this is ME/CFS, this
yes,
with some slight variations, but.
Well, he's also said that that post-COVID syndrome has many of the symptoms of ME/CFS, and he's implying that they are the same.
Okay.
He stated that publicly, but you're right. It would be better if they just called it ME/CFS and sent people in the correct direction,
Right. Yes, exactly. So I definitely want to get to vaccinations in just a second, but first I'm really curious, how did you come to specialize in ME/CFS and these related syndromes?
I was practicing internal medicine and pediatrics in 1983 in the city of Raleigh, North Carolina. And there were 2 outbreaks of chronic fatigue syndrome. There were one in the North Carolina Symphony and another in a Fortune 500 company. And those people started coming to me. I was known in the area for dealing with more complex diseases. And so they came to me and were seeking an answer as to why they had a flu-like illness from which they were not recovering. And after a while, I realized we had 100 or more people with chronic fatigue syndrome. And I called the Center for Disease Control in 1985. And they said, well, that's interesting because we have 2 doctors out in Lake Tahoe who have 300 patients out there. And we have 2 pediatricians in the Rochester area who have 200 patients up there with what looks like the same thing you're seeing in Raleigh. And so at that point, they decided to get a team together and investigate all of these 500 or 600 people with chronic fatigue syndrome. Of course, we didn't call it that at the time. It was not until 1988 when the first paper was really written about it, and it was given the name chronic fatigue syndrome.
This is fascinating because I didn't realize that history about it. I tend to tack on the ME, the myalgic encephalomyelitis as well, because I think it's probably totally ego related, but I remember when I told people that I had chronic fatigue syndrome, it comes across as just, oh, well, you're tired, you know?
Yeah, and I'm tired too.
Right, exactly.
Yeah.
It doesn't.
And you're right. About 37% of people prefer to use the term ME, MECFS, or ME. And it's about 30% of people want to call it chronic fatigue syndrome. So mostly researchers, because when you use databases to look up articles, you have to use chronic fatigue syndrome. That was the official term for so many years. And then there's a few that call it other things like SAID, systemic exertion intolerance disease, which was the official government name that was given in 2015.
I, again, had no idea. That's
I got you.
You got, well, yeah, you, like I said, you're the, you've been in this game since the 80s, which
That's
is
correct. Yes.
Yeah, incredible. So yeah, let's get to the vaccinations.
Sure.
So lots of questions here. A lot of them came in after I sent you that last email. But let's start off with the basics. Which ones are available right now to people, and which ones are best for, which ones would you recommend specifically for people with long COVID? And then for people who have MECFS, pre-COVID.
Okay. Well, there are 2 currently available. One is by Pfizer and the other is by Moderna. The Pfizer one is the one that has to be kept at the very low temperature. But I think they just applied this week to the FDA to keep it at a more typical temperature of 5 below 0 Fahrenheit. And so that will allow it to be kept in a typical freezer rather than the special laboratory freezers that we had to use. We had to use freezers that kept it at 80 below, and typically we store blood and specimens at that temperature. The Moderna one is kept at refrigerator temperature, standard refrigerator temperature, so it's not much of a problem. There's a third one that's about to come out by Johnson & Johnson, and we're hopeful for that one. So let me tell you the difference between the 3. The Pfizer one is the one that has to be kept very cold, and Moderna is a regular refrigerator temperature. It's kept at. They both work in a unique way. They have a microRNA that is connected to the spike molecule on the virus. Are you familiar with that? The virus is like a round ball with little spikes on it, little red spikes. And those spikes are the antigenic part, and they're the part that actually attaches to a cell and infects a cell. And so the Moderna and the Pfizer products, they have copies of that spike protein that are then injected into an individual with the vaccination. and that causes antibodies to develop against that spike protein. So now when a coronavirus shows up in the body, usually in the nose or the throat, and the body senses those spike proteins, it will immediately attack that. The innate and the humoral systems, the immune systems will attack that virus and eliminate it from the body. Now, the third vaccine is made by Johnson and Johnson, and they've applied for emergency approval, I guess is the way to put it. EUA, we call it, emergency approval. The difference there is that the spike protein is attached to an adenovirus, which is a common cold virus. And basically what they're doing is giving you a minor cold with the virus spike on there, and that's what develops the antibodies. So the importance of that is many patients with chronic fatigue syndrome don't tolerate vaccines that have viruses in them. Influenza vaccine, the measles, mumps, rubella vaccine, the hepatitis B vaccine, the hepatitis C vaccine, they're all known to trigger flares and relapses in patients with chronic fatigue syndrome. And so unless you've taken them before or have experience with vaccinations, we don't recommend using live or attenuated viral vaccines. So that's what the Johnson & Johnson one is. It's an attenuated adenovirus vaccine. So I wouldn't recommend that for patients with chronic fatigue syndrome. The advantage to it is that the Moderna and the Pfizer require 2 immunizations, at least 3 weeks apart, and typically 6 weeks apart. Whereas the Johnson & Johnson is only 1 vaccination. The other thing about the Johnson & Johnson is that it was tested in patients that have the South African variant, which is the more virulent and the one that's more likely to spread, and the other 2 have not. We think that the other 2 are not quite as active against the newer mutations of the virus, like the one from the United Kingdom or the one from South Africa. And so those companies are working on modifications of those particular viruses. But right now, if you're afraid of being exposed to the South African virus, you need to wait for the Johnson & Johnson, I think.
That's great. That's one of the, you're answering questions before we even get to them. So thank you. So for people with long COVID, what is your recommendation for, and I want to do both. So yeah, for people with long COVID, what's your recommendation for which one of those 2 that are available right now for them to do?
Either one, they're fine. Yeah. Now,
okay.
if you've had COVID and you have long COVID, then you probably already have antibodies. And so if you take the Pfizer or the Moderna, which are currently available, you only want to take 1 immunization because you already have the antibodies. If you take 2 vaccinations like they recommend, you may have an adverse response to it. It stirs up the immune system too much. And it may actually make things worse. So 1 vaccine if you've already had COVID. If you have ME/CFS, or if you're an individual who's healthy and want to take the vaccine, then you need to take the 2 injections, the 2 jabs of the Pfizer or the Moderna.
Perfect. So for people who do have long COVID,
yes.
For instance, I know that I went to get an antibody test after, within the allotted time that was recommended.
Yes.
So not too close to having active COVID, but not too long afterwards.
Yeah.
And the test came up negative.
Yes.
So for something like that, or for someone who had COVID initially, say 6 months ago or a year ago, would it be best to get the 2 jabs, or what do you? what's your recommendation there?
I'm not sure what question you're asking there.
Okay, I think I'm asking two questions.
You know, why was my test negative, and how many immunizations should you get?
Well, yeah, I think that's part of the difficulty with it, is that I know that I had COVID, but since the antibody test came back negative, should I still get the 2 jabs, or should I assume that the antibodies are still active and just go for the one?
That's a good question. I don't think anybody can answer that with scientific evidence. I think I would definitely get the 1 jab, to tell you the truth, because there should be some memory of that infection in your body, in your immune system. And that memory is just not strong enough to show up on the test, on the PCR test that they do. But there's probably some memory in your body. So I'd probably just take the 1 stick of the Moderna or the Pfizer.
Okay, awesome. Yeah. So probably the same thing for people who had their COVID infection, you know, a year ago or
that. Yeah, absolutely. Yeah.
Okay, great. That is excellent.
You know, I think it's important. We make a point right here that you can certainly catch COVID a second or a third time. Repeat COVID has been reported several times now, numerous times, as a matter of fact. And so even though you've had the illness, it doesn't mean you're immune. You still need to wear your mask and wash your hands and keep your social distance and don't get into trouble. You know, don't go to
keep your nose clean, literally.
Right. Exactly. Yeah. The first thing is prevention, and so you want to keep that up even if you've had COVID. I've had patients with COVID say, well, now I'm safe. I have the antibodies and I'm safe. And you know, we've seen the antibodies last anywhere from a few days up to 4 months. I've seen documented in the literature, maybe longer, but you just don't know. You just don't know. So that's why some people can get COVID more than 1 time.
Yep, sure. And especially with these strains.
Prevention is the thing. That's the thing.
Yep. Yeah, beautiful. So let's see our next question here. This is interesting. Thoughts on some of the long haulers whose symptoms have improved after receiving the vaccine? Could this be due to viral persistence being cleared from the body?
I don't think so, but I haven't heard of any cases like that. I think it may be circumstantial that happened. I wouldn't expect that the vaccine would make the symptoms any better. I think it may have just been coincidental that happened at the same time.
Okay, great. Great. So this is from someone who actually has had their first dose of Pfizer vaccine 8 days ago. And she said, I had a very inflamed and very red throat for 8 hours afterwards.
Yes.
And then also someone else who still has nerve pain at the injection site after a flu shot. And this has been like 8 months, maybe not 8, but about 4 months later or more. Yeah. Should she be concerned the same thing is going to happen with the COVID vaccine shot? So I guess we're talking about reactions to the shots here.
Well, I think we see more reactions to live viruses or attenuated virus like the influenza vaccine. So that individual that had that persistent response probably would be able to tolerate the Moderna or the Pfizer vaccine because it's not a live virus.
Okay.
Yeah. So I think that pretty much answers your question there.
Yes. Yes. So we did address the new variants. And you said the Johnson & Johnson one, when it comes out, is going to be the best one for those.
We believe so. It was tested. The efficacy numbers were done on patients who had the South African variant. So okay. When they say it's 60% effective or 85% effective or 100% effective, it's because it was tested in patients that had the South African variant.
Great. Okay. So, do you know of any organizations that are tracking the vaccine experiences with our long haulers?
Not the vaccine experiences. No, I don't know any that are tracking the vaccine experiences. I know there are several groups that are tracking patients who have had COVID, and particularly looking at long haulers, because we're hoping to learn something from the long haulers that will help us to deal with chronic fatigue syndrome, or MECFS. Yeah, we're hoping that the one will open some research doors to the other. So there are groups, and probably the biggest group that I know of is the National Institute of Health, that has a study where they're collecting data from long haulers, well, patients who have had positive COVID testing. But there are several groups I know out there that are doing that.
Great. Yeah. Yeah. And I had the same thought when long COVID became a thing.
Yes.
I was like, I hate that so many people are having to experience this, and it is not fun, and I feel for them. But at the same time,
The studies have shown so far that at least 10% of people that get COVID end up as long haulers. And it's as high as 50% in people who have been hospitalized or been on a respirator for it. So the prevalence is very high. And when you consider that as of today, there's over 25 million people who have had COVID. If you just use the lowest number, 10%, that means there's going to be another 2.5 million people with basically long COVID or chronic fatigue syndrome walking around. It's staggering. It's absolutely staggering, because there are only 10 or 12 centers in the United States that deal with chronic fatigue syndrome like we do, where we see that all day, every day. And there are a few people who have an interest in it, but 10 or 12 people taking care of 25 million, or 2.5 million, I should say. That's just not a good ratio. We're going to have to find a better way to deal with it.
Yeah. Yeah.
Are you aware of the support group, the Body Politic?
Yes, that's I do workshops with them, and I'm very involved with them. I love, oh my gosh, so comprehensive, wonderful group.
Exactly, right. They've done I think 3 papers now. As their experience grows, they only accept members who have had COVID-19, and they track those people over time, particularly those who've had symptoms more than 3 months. And they're keeping the kind of data that you were just referring to, and they make it available online. They make it online to anybody, including the press. So it's been a very valuable resource.
Yeah, I think
they're easy to Google and easy to connect with on the internet. And if you've had COVID, and particularly long COVID, well, it is a long COVID support group. So if you have long COVID, that would be one place to sign up for and get their ongoing information about dealing with the illness.
Yes, great. And come to my live workshops. They're
There
free.
you go.
They're every other week.
Right.
Yeah. So let's move on. I think we've covered what we wanted to with the vaccine so far.
Okay.
You mentioned this earlier about the long COVID centers. You just touched on it, but that was one of the things that in that article that you wrote, that was wonderful, by the way. It was amazing. Yeah, but that was one of the things that really stood out to me, because I was wondering about those long COVID centers. I have a couple of students and clients who are starting to go to those, and I was a little cautious about it. So what can you share with us, kind of what you shared in the article and other thoughts about those?
Well, my big concern is what we discussed a little bit earlier, and that is that they won't recognize MECFS, and they won't recognize the the comorbidities that go along with the post-viral fatigue syndrome, like the POTS, for example, which is very common in COVID, in long COVID. And the other thing that we've heard, which is frightening to those of you who have had ME/CFS or have had COVID, we've heard of many patients, not many, we've heard from a few patients who have gone to these centers, and they were told that the symptoms that they're having are all psychological, that just, oh, I know, yeah, just bear with it and they'll go away. It's just a virus. And, that's not always the case. And I don't think that recognizes how severe these symptoms are and how they affect lifestyle and work and study and so forth. So I think there are a variety of centers out there, and some of them are just collecting people so that they can have data that they can write papers about, and some are very honestly trying to help. Oh, and there are some that are trying to do research to find out what we can do to treat it and treat the patients that do develop into ME/CFS. So,
Right.
in other words, there's a spectrum of clinics out there from what I'm hearing, because we hear from patients all over the country that call us for advice and information, and that's what they tell us. So I'm passing it on second and third hand, I guess.
Gotcha.
Okay.
So yeah, that's good for us to know, for people who do have those centers close by, and just to know that you might need other help along with the long COVID center, and to be your own advocate. I guess that's what we run into.
That's exactly right. You have to be your own advocate. You have to be your own doctor, because there are not a lot of people who understand this. And the best thing you can do is to find a sympathetic and empathetic provider, whether it be a physician or a PA or a nurse practitioner or whatever. But find someone who's empathetic and willing to learn about it and help you through it.
Great. Yeah. So this is a loaded question, but I'm going to go ahead and ask it. Because you have so much experience in this area, is there any hope for treatment to eliminate symptoms instead of just making them slightly worse or just a little bit better?
Oh, absolutely. Yeah, absolutely. There are numerous treatments in order to manage the disease. We don't know, because it's so early in the game, so to speak, what the long term is going to show for the long haulers, whether they're going to totally recover. But there certainly are treatments available. We've been working on one called Ampligen since 1988, actually, a drug that treats ME/CFS. And it's been shown to be safe. And we've been trying many years to prove that it's effective. It's hard to prove something is effective when the symptoms are things like fatigue and pain. And exertion intolerance. How do you measure those things?
Right.
And that's why the drug has not been approved so far by the Food and Drug Administration, because it's hard to prove that it's effective. But we certainly have many patients who have improved on that, and the papers that we've written show that up to 50% of the patients have significant improvement from the medication. But we're using it in patients with long COVID now, or planning to. We have a research grant to do that. And
great.
We're hoping if we can get patients very early in the game and treat them with the Ampligen, that we can chase those symptoms away. But to answer your question, there are a lot of sleep treatments, there are a lot of pain treatments, there are treatments for fatigue that we have, there are things that we can do for the cognitive issues that patients have. So yes, we can treat the symptoms, and we can treat the comorbidities that go along with the illness, like the irritable bowel and the bladder problems and the vitamin deficiencies and so forth. So yes, if you can get in touch with someone who's knowledgeable about ME/CFS, they can help a lot in those different areas. And another thing about dealing with an expert is that when a doctor doesn't know exactly what's going on, when they're confused, then they tend to fire a bunch of tests and studies on a person. And we see many people who have had virtually hundreds of tests and thousands of dollars spent on testing that was unnecessary because we already know it's going to be abnormal or it's going to be, or we know it's going to be normal or abnormal in a person with chronic fatigue syndrome. So by seeing a specialist, you can avoid that overuse of studies. Does that make sense?
Oh gosh, yeah.
Okay.
Yeah, it's like, yeah, well, you said it perfectly. You really did.
Yeah.
When they don't know what's happening, they are gonna do a shotgun method as opposed to people like you can go in there with a scalpel and, get at what's really happening.
Precisely.
Yep. Yeah. That's,
I guess two big examples are about 80% of people with ME/CFS have little white spots in the brain when you do an MRI. And to someone who's untrained, they may think that that's MS, or they may think that that's migraine. They may think that it's Alzheimer's disease. There are a lot of other things that have little abnormal brain spots, what we call unidentified bright objects. But they're common in chronic fatigue syndrome. So we've seen many patients that have had an MRI and get sent immediately off to the rheumatologist to rule out, or the neurologist rather, to rule out multiple sclerosis. And it's a waste of time and energy and money.
yeah.
Yeah. Another one is that the endocrine system is abnormal in patients with ME/CFS. And if you go to an endocrinologist, they fire a panel of tests and they see these things and they say, oh my God, you have a terrible problem here. And it leads to an enormous amount of testing that's fruitless because we already know the abnormalities occur in patients with ME/CFS.
That's fascinating. And I just have to say that the unidentified bright
Objects, yes, ma'am.
That just that kind of cracks me up because it just sounds like UFO. They're brain UFOs.
Yes. It's the same thing. I know exactly what you mean.
That's okay. It's fascinating. So, this is a really interesting one, and it's dear to my heart. But I'm running across it with other people too. Have you found connection between weather and long COVID and ME/CFS flares?
Yeah.
Please talk to me about that. So I just want to give a teeny bit of background here because even when I had chronic fatigue syndrome severely for 8 years a while ago, and now I do have a mild version of long COVID. But even when I am not ill with either of those, I still have these crazy things that happen when fronts come through and troughs are happening and all this stuff. So
yes, yeah. High humidity is another one. Too hot, too cold. All of those can affect our patients. And I have many patients that are seeking the perfect climate, so they end up in central or southern California or Arizona or something like that. And darn if they don't find the weather changes there too, so it doesn't do any good.
Right, and especially these days. But what's fascinating about this with a lot of these people, so specifically, this came to my attention with one of the workshop participants. Both she and her 2 daughters have long COVID, and they find that they all have a flare up or a crash at the same time. And it doesn't have anything to do with, overexerting or food that they ate or anything like that. And so my first thing for them was for her to start tracking the weather and to see if
it's a good thought. Yeah. I've never heard of that where a whole family has a flare at the same time. It's a little bit unusual. I would think something as diverse as the weather would probably be the cause of something like that.
Right, yeah,
or a stress. Let's not forget there are other things that make ME/CFS worse. Stress is a big one, and it doesn't have to be doesn't have to be a fight or a conflagration or a confrontation or anything like that. It can be just too much clutter around the house. That's a stress that really bothers most of the patients with ME/CFS. Or too much mail building up on the kitchen table. The laundry piles get higher and higher. You know, what I call Mount Washmore, the laundry pile.
I'm going to use that.
There you go. Yeah, you're welcome.
I'm definitely, yep.
But yeah, and menstruation can do it too.
Yes.
You know, most of our patients, the majority of our patients are female, and menstruation can do it too. And so there are a number of factors that can trigger flares or make our patients worse. But those are probably the three biggies: weather, menstruation, and stress.
Gotcha. That's
And of course, infections. Any sort of an infection will trigger it off too.
right. Right. So another question that came in was around adrenal surges. So
Adrenaline surges.
yes.
Yes. Yeah. Yeah.
So what can people do to help to chill those out, for lack of a medical term here?
It depends on what you mean by an adrenaline surge or an adrenal surge, whatever you want to call it. Most of those are autonomic phenomena, and it's due to an increase in norepinephrine in the bloodstream, which causes the heart to race and the mind to race, and it disturbs sleep because you have racing thoughts at night. And these are all autonomic phenomena. Um, that's probably the most common cause of those kind of feelings. But I have also had patients that would describe those surges as brain zaps. They have a feeling of like electricity shooting in the brain or electricity shooting through the body. And if you call that an adrenaline surge, we don't really know what that is. We think that that's a nervous system problem, an abnormality in the nervous system that causes a spark, if you will, and causes those kind of zaps. So are there any other adrenaline surges that you can think of?
Well, I think she was talking specifically about, for her, it is very much linked to her menstrual cycle. And to be honest, I didn't quite understand the question, but I do know that for myself, early on, after recovering from COVID, anything could get me to the place where I was shaking and just, adrenaline through the roof. Any small little thing. I specifically remember 4th of July because my neighbors had a bunch of people over out in the street right in front of our front yard. And I was about to come out of my skin because the fireworks were going off all over the place. And I sat myself out on the front porch and had to keep telling people to, and when I went to talk to my neighbor the next day, I was shaking so hard that I could barely talk. I think because of all the adrenaline.
Yes, yeah. And I don't know if that's so much adrenaline. It's a well-known fact that people with ME/CFS, they're hypersensitive to everything, sensitive to light, sensitive to sound, sensitive
Yes.
to temperature, sensitive to chemicals, odors, fumes, smokes, perfumes, sensitive to medication, sensitive to foods like wheat and dairy. And so there are these numerous sensitivities and allergies, if you will, that develop when you have chronic fatigue syndrome. And one of those things that is most upsetting to our patients is the kind of chaos that you were talking about, where fireworks are going off or kids are running around screaming and having a great time. it might be fun for them, but it's hell for a person with ME/CFS. And I
Yeah.
know you've been there.
Oh yeah, the leaf blower, the first round that I had, 20 years ago, the leaf blower was like my worst enemy.
There's a current philosophy that's due to inflammation that occurs in the brain. The microglial cells in the brain become inflamed and angry, if you will. And that's what causes that kind of hypersensitivity to occur in our patients. There are a couple of things. There was a recent article about using very low doses of a drug called Abilify for that. And we also use a drug called naltrexone to calm down the glial cells. So
What was the first one that you said?
Abilify,
Abilify. Oh yeah.
Yeah.
Yeah. I ran across that somewhere. Cool.
Yeah. So there are a couple of things that people are trying to reduce brain inflammation. One of my dear colleagues down at the University of Alabama has shown that patients with chronic fatigue syndrome, the brain temperature is higher than normal healthy people, which probably is a sign of inflammation, and that lactic acid levels are higher in the brain, which is probably another sign of activation. He's currently studying, this is Jared Younger, by the way. Many people will know that name. Yeah, at the University of Alabama at Birmingham. He's currently studying and believes that he will find that there are white cells in the brain, which are normally not there, but apparently they're able to pass the blood-brain barrier and cause inflammation, or to use a vulgar term, pus in the brain. And so
say that again. Over what kind of pus?
I was saying, to use a vulgar term, there are white cells in the brain, which is basically like having pus in the brain.
Oh, okay. Okay.
And he's concerned that may be causing some of the inflammation that we see. So how do you keep the white cells out of the brain? How do you keep the blood-brain barrier intact? Those are things that Jared's working on. Yeah, fascinating stuff.
Yeah,
so you see, that's just more of the things that you asked, are the things that can be done. And there are a couple of things right there. If people have these terrible sensitivities, we can start addressing those and tell them how to deal with them effectively.
Beautiful.
Yeah.
I love that. I love that. So
there's another adrenaline rush too that I sometimes hear about, which is why I said to you, you have to tell me more about what you mean by an adrenaline rush, because there are a bunch of different ones. And a very common one is due to the orthostatic intolerance, where a person stands up and they get very dizzy, and they may see stars, or they may get tunnel vision where it gets dark and closes in on them, or they may even be fainty. That's right.
Yep.
Yeah, absolutely. Yeah. And that orthostatic intolerance causes the heart to race, and it causes autonomic symptoms. And so people get the feeling of a rush, if you will, when that happens. And so some people will describe that as their adrenaline rush. So I guess we've sort of defined 3 or 4 different rushes, haven't we? Huh?
Yeah, I think so. I think we've covered it. We'll see if that answers her question. I think it probably does. So we kind of talked about parents and children both having long COVID. There are a couple of other people that I've run into who, one person in particular, his daughter has had chronic fatigue syndrome for many years, and now he has developed long COVID. So wondering if you've run into any genetic component as far as being more susceptible to having it turn into ME/CFS.
Not yet. I think that's one of the things that's being studied is, in other words, are there certain people have a predisposition toward ME/CFS?
Yeah.
And we think that there are. And there are some genetic studies that would suggest that there are genetic susceptibilities. But I don't think we know that for sure yet. And that's one of the things that people are studying and hoping to get out of the whole long COVID thing, to see if some people are more susceptible to it than others. Yeah.
Great.
So I certainly know of studies that are looking into that.
Okay.
But we don't know yet. We don't know.
Right. Right. And, you know, since so many people are developing long COVID and therefore ME/CFS, my guess is that all of this is gonna.
Yeah. I just want to be clear that ME/CFS is not infectious, though.
Right.
Yeah.
Right. Yeah. Yeah. But my hope and my guess is that all of this research is gonna go faster.
Exactly. Exactly. Wouldn't that be lovely?
Man, I mean, I didn't even know about you when I first had, you know, when I first had it those many years ago. So I, you know, the internet had only been around for maybe five years or something, as far as being accessible to everybody. And
Yeah.
there was just there wasn't anything out there. So I'm so glad that you have been there for so many people, and continue to be able to be a leader, you know, with what we're dealing with now, to be able to educate people around this. Yeah, because there, like you said, there are things.
I wish I had your energy and your enthusiasm to do these things.
You caught me on a good day.
Hard for years, but
yeah, no, I really, when long COVID started, because I think I told you that I have been coaching people with chronic illnesses for about 20 years now.
Yeah.
And developing these strategies and taking things from other places and develop the course and everything. But I hadn't developed the course until long COVID hit. But when long COVID hit, and I started to interact with, you know, people who, because you know very well, it's like being thrown into a completely new body within a week or two. And it's, you know, confusing, and especially if you don't know what it is. And so once long COVID hit, there was like a fire lit under my butt to you know, to reach out to people to say, hey,
good for you. Good for you.
This is doable. Like,
yeah,
following these strategies and going to specialists, and yeah.
Right.
So, Dr. Lapp, do you have anything else that you'd like to share with us? This has been absolutely incredible, and I really appreciate you kind of bearing with me at the beginning with the technical stuff, and I'll get that worked out. But yeah, anything else you'd like to share?
I just think it's important to say that there's hope and there's help out there for the folks with the long COVID, and the folks with the ME/CFS as well. And as you pointed out earlier, you have to be your own advocate. You have to be your own doctor, and learn as much as you can about these illnesses that you have, and use resources like your website, and hopefully people will use our website. We have 2 treatment websites that are out there, and I think that's the important thing, is that you must not lose hope, you must not feel discouraged by it, because there are things that can be done. Does that help?
That's giving me goosebumps and tears and stuff. Yeah, that's beautiful. Yeah, thank you. Thank you so much. This has been invaluable. And I will send out to people both of your websites. I'm going to write that down as well. Give me just a second here. And yeah, so I'm going to make sure to put all of that information in with the recording and the email, you know, with all of this.
Excellent.
And what was that?
I said, that's great. The goal is to help people. And
yes.
That's why we've developed these sites, so that you have resources.
Yes, perfect. And I was also going to say that I know that you have a wonderful form to help people get their doctors to basically to help get disability.
Yes.
And I know that I ran across that somewhere. Where do you remember where that is?
I don't.
I'll see if I can find it again.
We developed that at one point, and I sort of lost track of it. But
Yeah, I'll see if I can find that again, because
that's a
that
whole
was,
other issue, and
yeah.
maybe worth talking about sometime.
Yes, yeah, I wanted to ask you about that, but that's like you said, that's a whole big other thing. So yeah, we might talk about that in the future. So, okay, so thank you again. I'm not great at saying goodbye, but I will say goodbye. I really appreciate it.
Let's not say goodbye. Let's just say until we meet again. How about that?
I'll be until. Yes, perfect. Until we meet again.
Great.
I love it. All right.
You take care. Thanks for asking me to do this. It's been fun.
Yes, me too.
Okay.
All right.
Have a
Bye.
great day and a great week.
You
Bye-bye.
too. Okay, bye.